Those of you who are visiting town, I recommend you walk up to the telegraph station, which is a nice walk along the Todd River, and it's the first settlement in Alice Springs and while the town was built. There you'll see a gravestone of Ernest Flint, and he died at age 33 of rheumatic fever and was the first Caucasian to die in Central Australia. I did look through the hospital record for his chart but couldn't find it, so I can't say how they diagnosed it. A couple of months ago we had a similarly aged person who came from a Western Desert community in Central Australia die of rheumatic heart disease. So we've not really made progress in this area. In Australia in 2008 it's actually very unusual to see a gentleman in middle age who's had a history of rheumatic fever, but it hasn't stopped Kevin Rudd getting to the top. And as Jonathan as well said, acute rheumatic fever is a disease of poverty, so it really occurs in the Aboriginal population. And in Central Australia in 2007 we had no cases in the Caucasian population. I've seen one case in the Caucasian in my time here. He was a gentleman of Kevin Rudd's age who'd had rheumatic fever as a child. And he got his episode whilst he was working as a plumber in an Aboriginal community. And this is really a disease, as Jonathan had said, which is a disease of the environment. So the first failure of meeting the needs is we haven't eradicated poverty. But let's look at the medical issues and how we're doing as a medical system of dealing with the disease that we have. So we certainly have a fair bit of disease in Central Australia, and we know of 603 on our register most recently who'd had rheumatic heart disease or a history of acute rheumatic fever. So how are we meeting the needs? So how effectively have we been at diagnosis? How effective at treatment? I'm not going to talk much about that. How good are we at delivering secondary prophylaxis? And one of the most effective secondary prophylaxis is actually going to be about eradicating poverty. So it's not just primary prevention. In the cohort studies that they did in the 20s and 30s and 40s, recurrences actually became less common as they went on, and that was pre-penicillin. So eradicating poverty is not just about primary, but is also about secondary prevention. How are we good at managing rheumatic heart disease, and what are our outcomes? So these are the number of cases we diagnose. So how many cases do we not diagnose? We don't know, so I called that Rumsfeld's number. So why don't we know about these cases? Where either people may not be presenting, and that may be patient factors, may be healthcare factors, or they may be presenting and we may be failing to diagnose. So I thought I'd just look a little bit at the factors about that. Now if we look at arthritis, we have quite a number of patients admitted with a presumptive diagnosis of septic arthritis. I've given top-end data because they've quantified it, where they did an audit of their adult cases of septic arthritis over a 16-year period, or 18-year period, and only about 1 in 3 actually had a definitive diagnosis. So there's quite a lot of undiagnosed sort of arthritis. And these may be people who are a part of a spectrum. So particularly looking at the original teaching about rheumatic heart disease, it was said that there was probably an inverse relationship between arthritis and carditis. So some people will fit in the middle. They've got both evident carditis and evident arthritis, and it's very easy to diagnose these people. Some people have carditis and they actually may be subclinical, and we do get at least half of our patients with rheumatic heart disease don't have any definite history of rheumatic fever, and they may be just getting carditis and no other manifestations, and so presenting later in life just with the cumulative effect of relative episodes. And on the right of the spectrum, we have those who just have arthritis, and they may not get the diagnosis because it's difficult to make the diagnosis. We make it on cumulative features. So this is just a quote from people with experience in the sort of 1980s, that is, patient with very severe arthritis infrequently had severe carditis and vice versa. So it's this inverse relationship. And there may be an age phenomenon. So carditis may occur more frequently in young people than in adults. So as an adult physician with an interest in rheumatology, I'm very interested in the adults, but it's those who get carditis, of course, which makes this such a disease of interest. Now, our diagnostic criteria date from the 1940s, from 1944, from Duckett Jones, who did cohort studies from the 1920s through to the 1950s, and his data provided the basis for the criteria we use. So, first published in 1944, so they're now getting on a bit, 60 odd years. And he stated that the migratory polyarthritis is generally considered the classic feature, but it is common, particularly in the young adult, but there is great diagnostic difficulty, whether the joint changes are objective or mere subjective complaints. And we still struggle. We don't diagnose these people well, and we actually don't have very good tools. So the criteria were actually adapted in 1965, where they added the need to have evidence of the streptococcal infection. But we've really not had major progress since then. So we're using tools which are 40 odd years old to diagnose this. And this is very different from a lot of other diseases. So we have had an adaptation recently to meet our no-call needs, published in 2006. But they're essentially the same with a few minor differences. But in particular, the fact that aseptic monoarthritis can be included, and I think that's an important addition. And also the use of subclinical carditis. And so hopefully by adapting these tools we may be better. Now Anna Rolfe and team published a paper where they looked at a prospective study of diagnosis, and there was still considerable uncertainty about one third of the patients who were the diagnosis was thought about. We still have many patients who have an arthritis in whom the diagnosis is not thought about. So I think we still are failing to diagnose many cases. It's partly about but the physicians. So I grew up, or I didn't see any in training, and so people are not being exposed to it and being taught in training, but also the tools we have are still challenging to apply for even people who are experienced. And there's also a challenge improving recent streptococcal infection, particularly where streptococcal infections are endemic, but I won't talk further about that. As I said, often the carditis will be subclinical, and so patients develop rheumatic heart disease without necessarily having any history of acute rheumatic fever or with misdiagnosis. And so we're now entering the era where we're maybe going to do screening, and Jonathan's mentioned the trial which is about to occur. We have had the health checks from the government intervention, and they managed to refer many people, all of whom had normal echoes, so I'm not sure how successful that's going to be. With diagnosis, we've also left with this issue. Are we going to be sure about the diagnosis, or are we going to broaden our criteria and improve the sensitivity, but maybe end up diagnosing some people who actually haven't had rheumatic heart disease, and we're still left with this quandary. So the treatment, not going to talk about much about the treatment because we have not much evidence, though eradicating poverty does be very effective in reducing the prevalence. And the other tools, aspirin and penicillin, are from the 1950s. We've tried to find further things to treat, but trials have been unsuccessful. So there's not a lot to say about treatment, although it is effective if appropriately administered. Secondary prophylaxis, Jonathan has talked about this, that penicillin is effective in preventing recurrent infections, as is eradicating poverty. How are we doing? We haven't eradicated poverty, and we've known about the importance of this for 30 to 40 years. Our tools haven't really improved. We're still using needles every month, so we're still using quite old technology. How effective is a modern health service at delivering it? We now have a register, which is good, but the register tells us that we are giving about half of the required doses. So we've still got a long way to go in terms of effectively delivering what we know to be an effective treatment. Management of rheumatic heart disease. We're hopefully doing well, but I don't actually have much good data. We're still getting deaths of people in their 30s. We're still getting deaths of people who've had intervention in terms of valvular surgery, so we've still got a long way to go here, and I think we actually need better data, and we actually need to use the registers to tell us how well we're doing and what the appropriate tools are. We are certainly getting more and more people in Central Australia having valvular surgery. I think many of them are still having surgery too late and maybe the wrong procedures. However, it's actually, repair is occurring, but still maybe not enough if that's a better modality, and it probably is. Outcomes. Look at the outcomes from Duckett-Jones series, which was before penicillin, and looking at this series, I can tell you why the paediatric wards were full of patients with acute rheumatic fever. They had a length of stay in hospital of between 6 months and 2 years. However, if you look at their cohort, 10 years after diagnosis, 20% were dead. 20 years after, 30% were dead. And of those deaths, 80% were due to rheumatic heart disease, 10% were due to endocarditis. We don't seem to have those numbers, but I think if we look at our deaths, we're still getting deaths at a young age, but many of them are actually living to die of other causes, which we are maybe achieving something, but I think we need better and ongoing data to tell us that. So my thoughts, we're not meeting the needs because we primarily have a failure to improve social determinants of health, which will be effective for both primary and secondary prevention. And we're also, our current medical system is not delivering mid-20th century technology for diagnosis and treatment effectively.